So good morning. For those of you who don't know me, I'm Russ Portenoy, and I chair the Department of Pain Medicine and Palliative Care, and I'm giving grand rounds today on a very exciting topic. That is the emergence of palliative care and hospice at a time of healthcare reform, and particularly at a time of very rapid change in New York State. So the goals this morning will be for me to talk about palliative care, what the current definition is, at least as we define it in the United States, and why palliative care has been emerging as a subspecialty. Then I want to talk about the current status of both hospice and palliative care in the United States. And then finally, I want to introduce some information about federal and state legislation that will have an impact on palliative care. So first of all, the question arises, why has a new subspecialty emerged, not only in the United States, but as a worldwide movement? And the issue and the main concern here is that patients who have chronic medical conditions have high illness burden. And there has been a question that has been evolving over decades about whether the current healthcare systems are capable of managing the illness burden of this enlarging population. Excuse me one second. So in the United States, in contrast to about 150 years ago, 90% of Americans die from incurable illnesses, and most patients who die in their 70s and 80s actually have multiple incurable illnesses. It's known from a variety of studies, mostly in cancer, some in HIV, and fewer in other types of illnesses, that patients and families have high illness burden as a result of poorly controlled symptoms, psychiatric disorders, and psychosocial and spiritual distress, concrete needs in the home, challenges in care coordination, communication, decision-making, goal-setting, caregiver burden and financial stress, and fear about managing the act of dying. Rather than spend an hour talking to you about some of the observational studies that have evaluated this in this country and others, I'll put this out there as foundational information. This information has ample evidence and support in a literature that now dates back about 60, 70 years. It's also clear that in the United States in particular, the burden of illness and access to health care is influenced by socioeconomic status and demography. And poverty and minority race, ethnicity are associated with worse access and poorer outcomes. And this has gotten into our lay press as well. I'm sure that you've seen articles in the last year about differences in outcome related to racial status. At the present time, we also have 50 million uninsured Americans. That may change in the next 2 years, or it may not, depending on what the Supreme Court does this summer. But at this moment in time, a hospital like ours in an economically disadvantaged part of the city must treat a very large number of uninsured patients whose costs of care are spread throughout the rest of the system. Equally important to the issues I just mentioned is the fact that in the U.S. we spend more for health care than anywhere else in the United States, anywhere else in the world, and the numbers are really staggering. These are data from the Organization of Economic Cooperation and Development. They represent data from the developed world, and you can see that if you look at total expenditures on health care as a percent of GDP, evolving between 1990 and 2007, the U.S. not only has the highest cost, but also the most rapidly accelerating cost. If you look at the cost of healthcare on a per capita basis, also data from the OECD, you see that the U.S. is probably about a quarter more expensive to care for patients who are ill than any other country in the world. And the question, of course, is we spend more money, what do we get from our dollars? And people in the United States generally like to spend a lot of money, but they like to get things in exchange for the money. So the question is, how are we doing with respect to these costs? What are they actually buying for us? Well, the first important point is that these costs largely take place in patients who are medically ill and to a very large extent in patients who are in the last year of life. 95% of the Medicare budget supports care for chronically ill patients, and about 1/3 of healthcare costs accrued during the last 6 months of life. That's really a remarkable statistic. So when you look at the gap and you say, how can we bring the cost of health care down in the United States? You have to say, who's taking care of the sick people? who's taking care of the patients who are likely to be dead in the next year. Because if we can identify who's taking care of those patients and how the care is rendered, that's where the low-hanging fruit is. Last week we had a presentation here at Beth Israel at the last chairman's meeting from an individual who works in Continuum and whose responsibility it is to expand access of the Continuum healthcare system to new programs that the government is setting up in healthcare reform, including medical homes, health homes, and accountable care organizations. And he gave a long presentation about the complexity of the system that we will be seeing evolve in the next few years. And the system is extraordinarily complex. And he went on for about an hour, and then I was forced to raise my hand, and I said, well, where's the money going to be saved? Because I don't see how we're changing the way we take care of sick people. Where are the sick people? And he acknowledged that much of what's happening now in planning for ACOs and planning for health homes and medical homes are focusing on preventative care, trying to capture patients who are chronically ill and keep them from getting sick. Less attention is being focused on the fact that everybody eventually gets sick, and when you get sick, you cost a lot of money. So I hope that in our institution and elsewhere in the U.S., we recognize that this is where the low-hanging fruit is, people who are already sick. Healthcare costs increase with older age, with the number of chronic medical conditions, and with decline in perceived health status. So if you're old and you have an incurable illness like congestive heart failure or chronic obstructive pulmonary disease, you probably have several of them, and you're declining, you are in the category that is driving costs in the U.S. healthcare system. So then the question, as I said before, is what does all the money buy us? And here are some data that sort of suggest that we have a problem in the U.S. Among the developed countries, the U.S. has the lowest life expectancy at birth. These are the OECD countries. The highest mortality amenable to health care. Compared to Australia, Canada, Germany, New Zealand, and the UK, the U.S. healthcare system ranks last or next to last in quality, access, efficiency, equity, and healthy lives, according to the Commonwealth Fund in 2007. And there are about 100,000 deaths per year in the U.S. from medical errors. So when you look at these data, it's hard to say that the U.S. has the best healthcare system in the world. You may hear that in political debates. That's spin. That's not fact. The U.S. doesn't have the best healthcare system in the world if you look at metrics like these. You can also ask at a more micro level, how is the system doing specifically in patients who have far advanced illness and may be approaching the end of life? This study in 2004 from Joan Tino and colleagues at Brown is still very relevant. I like this study because the results resonate with our own experience so nicely. This was an after-death interview of 1,578 family caregivers, and it asked questions about the care that was received by the decedent, by the family member who died, as perceived by the caregiver after death. And it asked a whole variety of questions. Now, these 1,578 family caregivers was a nationally representative sample that represented the mainland United States. So this projects to the U.S. population. And the results show that about a quarter of the family caregivers reported concerns with physician communication during the period of time right before their loved one died. About a quarter said that their loved one had uncontrolled pain or breathlessness and did not receive adequate treatment for this. About a third reported insufficient emotional support. And when the family member was asked, was the care that you received poor, good, or excellent, only 50% of patients who died in institutions or nursing homes had family members report that the care was excellent, and 71% of family members who had patients involved with hospice said the care was excellent. So end-of-life care, as perceived by the families, for the majority of people who die in the United States, who die in institutions, is not excellent care. That's the perception. And about a quarter of the patients who die, according to the families, have uncontrolled pain or dyspnea. And there are problems with physician communication and emotional support. This study doesn't suggest that the problems are 80%, 100%. It suggests that there's a core group of 25 to 33% of patients who die who don't get care that provides an end-of-life experience that adequately supports them. So, and that, I think, resonates with our own experience. Another issue for care in patients with advanced illness is whether or not the healthcare system is able to respond to the patient's values and preferences. And it's hard, obviously, to think about a valid metric of this, but one metric that has been proposed is the extent to which we're able to provide people with a place to die of their preference. And in surveys of patients and healthy people, around 3/4, there are some studies that go down to 50%, so if you want to be generous about it, just say that of all the surveys that have been done of both sick people and not yet sick people, between 50 and 75% of the people surveyed say that if I had adequate support, I would like to die at home. Unfortunately, about 3/4 of Americans die in institutions. And so this is sort of some evidence, a bit ambiguous and needs a little caveating, but the bottom line is that there is a disconnect between the values expressed by Americans in terms of their desired place of death and where they actually die, suggesting that the ability of the healthcare system to respond to the needs at the end of life is less than it should be. So what's the conclusion? We have a situation in the United States where we have more than 2 million deaths a year. 90% of those deaths occur in the context of chronic incurable illness. We have an aging population. By 2030, 30% of Americans will be over the age of 70, I think it is. We have a huge bubble of aging, sick people, and this is leading the healthcare system to have to deal with a large and increasing population with serious or life-threatening chronic illness. We know from data in the literature, your own experience, that chronic illness, particularly when it's advanced, is associated with high illness burden in multiple domains. And we have evidence to suggest that the current system of care does not meet the needs of a significant proportion of patients and families, is highly variable, has significant disparities by race, ethnicity, and socioeconomic status, and may increase the potential for inappropriate or unnecessary therapy, leading in part to the reality that our care here is extremely costly but doesn't offer more quality than less costly systems in other developed countries. So that's the status. And it's not a pretty picture, unless you're a managed care organization. But that's not a good picture. But that's the status, in my view. So we need solutions to the status, and palliative care has emerged as an international movement manifested in an extremely heterogeneous group of healthcare systems evolving all around the world, in part to address the unmet needs that I just described. In the United States, palliative care has emerged as an interdisciplinary therapeutic model. It's an approach to care. That's how I think about palliative care, whether here or elsewhere. I think about it as a model. It's a model of providing care. And it's a model of care that's appropriate for all populations with serious or life-threatening illnesses, the goal of which is to prevent and manage suffering and illness burden for both the patient and family from the time of diagnosis onward. In fact, 10 years ago, between 10 and about 15 years ago, I spent many hours working with others trying to come up with an 8-second soundbite for palliative care. So we couldn't get it to 8 seconds unless you say these words very fast. So palliative care is an interdisciplinary therapeutic model appropriate for all populations with serious or life-threatening illnesses, the goal of which is to prevent and manage suffering and illness burden for both patient and family from the time of diagnosis onward. And you're going to, no repeats? That's palliative care. For our trainees in palliative care, you will have to develop a definition that you can say standing in the hallway with a cup of coffee in your hand. You may want to think about this one. It's not that they understand it, they don't, but you can say it without putting people to sleep, and then it opens the door, in my view. So it's not end of life. I think the important thing here, in part, is what it's not, right? It's not end of life care. It's not hospice care. It's not domiciliary care somewhere in a building somewhere. It's a therapeutic model. It's a therapeutic model. And you can conduct the business of this therapeutic model in any number of ways. And if you look at countries like Romania and Estonia and you compare it to the UK, Australia, United States, you see tremendous differences in the way the model is implemented in healthcare systems around the world. Okay? So what are the key features of palliative care? First of all, it's about multidimensional concerns that are within the purview of multiple professional disciplines. It's about physicians, nurses, social workers, pastoral care providers, speech therapists, dietitians, physical therapists. All disciplines can potentially deal with the domains that are relevant under a palliative care model. It's relevant throughout the course of the disease. End-of-life care is a slice of palliative care. It's a slice that most specialists spend a lot of time worrying about, but it's a slice, which is good since we're so poor in predicting when the end of life is, that if you actually said that this discipline is only appropriate for the end of life, you'd have trouble because you can't really predict when the end of life is. Parenthetically, that's one of the problems with the hospice model in the United States, predicated on predicting when the end of life is, and we don't do a good job with that. The patient and the family are considered the unit of care. That's no longer so dramatic in the U.S. with patient-centered patient-centered home health systems and patient-centered medical homes coming along. They now recognize that this is critical. Palliative care aims to promote comfort through symptom control. These are the key domains. Management of psychosocial and spiritual distress. Communication that supports patient-centered goal setting, shared decision-making, and advanced care planning with due regard for culture, religion, and other sources of variation. Palliative care is concerned with providing adequate practical help, instrumental help at home. It is concerned about the expert management of active dying and its aftermath, and it's concerned about family support when caregiving and when bereaved. These are the domains, the key features, the objectives of palliative care. Now, in the United States, about 10 years ago, a very important conceptual initiative evolved. I think in my own view, when the history of palliative care in the U.S. is written in the future, this will be deserving of a chapter. That this happened in the United States was very important. It may not have, this was not preordained. The fact that in the United States we have evolved to a model of palliative care that includes recognition of generalist versus specialist level care was not preordained. This was a decision. This was actually a group of people getting in a room together over a period of years and saying, we got to promote this. So, and in some countries, as you know, or you may know, this is not really evolving as it has in other countries. There are a few countries around the world where it's quite mature. The Commonwealth countries like the UK, Australia, New Zealand, Canada, and we're a new arriver. The US is a new arriver. So this is a very important element of the palliative care model in the United States, the recognition that it can be generalist level care, in which case it could be defined as a best practice during the routine care of all patients with serious or life-threatening illness, and the fact that the palliative care model can be provided at a specialist level. And what's specialist level care? It's an interdisciplinary service for patients or families who require a team of professionals with special competencies. So if you're thinking about generalist level care, those of you, for example, who will be leaving here and going to other institutions and trying to do specialist care, to the extent that you can articulate what generalist level care is and place expectations in that system to make generalist care a best practice, you will make your lives a lot easier and help the patients that you can't touch. So what's generalist care? Generalist care is provided by clinicians in any discipline. In my view, it involves multidimensional assessment, an effort to intervene in any of the palliative care domains, key domains, and knowledge about when to refer. Those are things that generalists do. Parenthetically, this model resonates very nicely in the U.S. because we're big into specialist medical care, right, for physicians. So, for example, if you're a general internist or you're a family physician, you know quite a bit of gastroenterology, quite a bit of cardiology, quite a bit of neurology. You're expected to be able to do an assessment of problems related to the gastrointestinal system. You're expected to have lots of interventions that can help people with GI disease. But you're expected to know when you don't know enough to provide adequate care and to refer. That's the model in the United States. And that model is exactly the model where a specific decision followed up by an action plan was made in terms of incorporating it into palliative care for physicians. This was done with an effort to create a common model with the rest of U.S. healthcare. So clinicians in any discipline can do these things, and we also have systems to support best practices, and they're called quality improvement systems, educational programs, and programs to reduce disparities and improve access. Specialist care is different. Specialists can still be clinicians in any discipline, for physicians, any specialty, or almost any specialty, maybe not pathology and in radiology, but almost any specialty. And, but the key thing for specialists is that we work in teams. That we work in teams that are either virtual or real feet-on-the-ground teams. We have high-level competencies through training and certification, and we provide program leadership and education with quality assurance and performance improvement. And we tend to work in two broad models in the United States: hospice and institution-based palliative care. Hospice and institutional-based palliative care are two structural models that have evolved in the U.S. healthcare system, in part to provide specialist-level palliative care in different contexts. So what's hospice? I'll spend just a second on that because I know this department should have a very good understanding about hospice. Hospice is a federal entitlement for more than 25 years in Medicare and Medicaid. It's under Medicare Part A. It has an equivalent benefit under Medicaid, and there are similar benefits that most people who have commercial insurance can access. It's a highly regulated managed care system. In fact, hospice under Medicare was the first managed care program in the United States. When you think about United, Oxford, or you think about Empire, you say these are big managed care companies, you say, what was the first managed care program in the United States? First managed care program in the United States was hospice. It was created by the government. For those of you who hate government, as some of you probably do, say to yourself, well, if this is good, isn't that weird that it was created by government? But it was government-created managed care program. And it's managed care, it's a full risk system for anything involving the terminal illness. Anything not involving the terminal illness is not covered under the benefit. Anything involved in terminal illness must be supported as a full risk commitment. And there are capitated reimbursements with 4 per diem levels of payment. And there's been a huge growth in the hospice industry since its inception. There's actually more than 5,000 programs now serving more than 1.5 million patients a year. And I actually went online a couple days ago. I should fix this. It's now a $14 billion industry in the Medicare budget. Started out as what some people call budget dust, and all of a sudden it's a big enough item so that the feds are worried that they're wasting money on it. And there's a lot of work being done now to change the reimbursement strategy for hospice, which may or may not devolve to the benefit of patients. We don't know yet, but it's being driven by the fact that this has become such a big payment out of Medicare. As you all know, hospice is not a place. It's actually a home care program. 90% of patient days have to be given in home. It's got very robust services for eligible patients, and it has limited access for inpatient beds. It's actually the best benefit in healthcare, as you've heard me say many times before, some of you. It's the only benefit in healthcare where you can get physician, nursing, social work, and chaplaincy services, drugs, supplies, durable medical equipment, access to inpatient beds, and a variety of other services, all without a copay, all without a coinsurance, and all without deductible. So it's the best benefit in healthcare. My view personally, as you've heard me say innumerable times, is if you have a hospice-eligible patient and you can get that patient on hospice appropriately, then those services are better, more likely to be better than anything else they could access. The regulations do not limit disease-modifying therapy unless it affects eligibility, but unfortunately, the hospice industry was set up as a managed care program with capitated payments, and as a result, if hospice programs are forced to pay for very expensive therapies, they will go broke. So the hospice industry has narrowed its eligibility requirements beyond what actually appears in the Federal Register. The federal eligibility requirements, it's been narrowed beyond that because hospice programs have had to do that in order to protect their financial viability. And in addition to that, there's a scope of practice issue. So most hospices don't give chemotherapy, for example, even the ones that are easy to give. They may say that it's a scope of practice issue, but honestly, for some of the chemotherapies, you know it's not scope of practice. The chemotherapies are relatively safe and easy to give, but it's a money issue. If they paid for chemotherapy, if you get about $4,000 a month from hospice, from the government to support a patient in hospice, and chemotherapy alone costs you $35,000 a month, in short order you will go broke. So hospice agencies are allowed to provide any disease-modifying therapy at all. There is nowhere written in the law that you can't have quote-unquote curative therapies, whatever that means in this context. There's nowhere written in the law that says you can't have therapies that will prolong your life. It doesn't say that. But what it does say very clearly is you can't have therapies that change your eligibility. And the eligibility is that 2 physicians have to attest to a 6-month prognosis if the disease runs its expected course. So if you have a gastrointestinal stromal cancer and you're near death, but someone comes up and gives you Gleevec, and we know that Gleevec is a remarkable chemotherapeutic agent for that particular cancer, and there's a reasonable likelihood that that drug will markedly prolong your prognosis, then you can't accept that patient on hospice. But having said that, as I mentioned before, most hospice programs don't allow a variety of treatments because of these scope of practice and cost issues. Now, the good news, of course, is if you get into hospice, you're very likely to like it. As I mentioned before, 71% of family members rated the care provided by hospice as excellent, compared to only 50% rating care from hospitals and nursing homes in the same way. And there are extensive data from patients and family members showing very high satisfaction and reduced health care costs when patients access the benefit. So hospice is a good thing. The problem, of course, is that we have great challenges. Ensuring quality and accountability across agencies that vary in size, location, community resources, and budget. Huge issue. By the way, the government is now into quality for hospice, and this year, in fact, hospice agencies have to now post their quality indicators on the CMS website, and in a few years they will be made mandatory. Some set of them will be made mandatory, and then undoubtedly there'll be a pay-for-performance model in hospice like there is going to be in hospitals. So we're moving toward a much greater federal requirement of quality being built into the system of hospice. And that has actually occurred also with the new conditions of participation that came out last year. We have to manage disparities between for-profit and not-for-profit models of hospice, a big problem. For-profit hospices can realize a surplus on their operational budget of 20%, whereas most non-profit hospices lose money. And so the government might say 20% is too high, we're not comfortable with this, we're going to tweak the system and destroy nonprofit hospices in the process. So it's a big issue. And we have to improve access to earlier and more appropriate referral. Hospice does have a referral problem, as you all know. I think it's multi-determined, widespread perception that hospice is a program for the actively dying, and the goal of which is a good death. In some hospice programs, that's true. In our hospice programs, that's not true. I mean, we're into the good death. It's not that we don't want you to have a bad death. Having a good death would be a good thing. But if you think about hospice as a set of services designed to provide specialist-level palliative care at the end of life, then you talk about service delivery. You don't talk about good death delivery. And Americans don't want to talk about death. They think it's sort of an optional thing, and they're not really that interested in it. So they don't want death. It's bad social marketing. Don't do the death thing if you're going to sell the product. So, but you can talk about services, the best benefit in healthcare, what you'll get, and that's a true fact. So we'd rather talk about services rather than the goal of good active dying, and that's a barrier because many hospice programs don't do that, and the general medical and nursing and social work and chaplaincy public doesn't appreciate that. As I mentioned before, doctors can't prognosticate, and if you set the eligibility for a program based on prognostication, but it's impossible to prognosticate, Houston, you have a problem. And we have a problem in hospice because of that. There's a widespread ignorance of a system that was built outside of the mainstream. Hospice as a benefit was built by people who are largely not physicians, done by grassroots organizers who believed that physicians were messing up dying. They looked over to England. They said the hospice movement in England was contributing to a human and more dignified approach to end-of-life care. All human beings must die. The way they're doing it there is different than the way we're doing it here. Here, it seemed like everybody would end up in an ICU with tubes and no choices, and there it seemed it was more dignified, more peaceful, more appropriate. And so grassroots organizers went to the federal government and basically said, this whole dying thing, can we take it away from the doctors? They're really messing it up. And the end result was the hospice benefit. So the good news is it's the best benefit in healthcare. The bad news, it was built entirely outside of mainstream medicine. You know, I mean, every so often I ask a young physician, who now in my world is most physicians, whether or not they know what hospice is. And the level of ignorance hasn't changed in my informal survey. The level of ignorance hasn't changed in 25 years. It's just unbelievable how little is understood about this healthcare system. Despite the fact it's a $14 billion industry with 5,000 agencies providing care to about almost half the patients who die each year. Unbelievable, right? And also, finally, as I mentioned before, the financial need of hospices to limit admissions because of the full capitation without outlier payments is a huge problem. So what about specialist-level palliative care programs in institutions like ours here? As you know, most are hospital-based. They have various components and services. Largely, they are more focused on physician medical care, less focused on other disciplines, in part because physicians can get reimbursed for services. But despite the challenges, as I'll tell you in a second, there's been an extraordinarily rapid increase in hospital-based palliative care programs, a 96% increase in hospital-based programs between 2000 and 2006. And in 2011, 63% of hospitals of greater than 50 beds and a remarkable 85% of hospitals of more than 300 beds have a palliative care program, according to the CAPC survey. So why is palliative care growing in hospitals and to some extent nursing homes? Why is it growing? Well, anybody who works in a hospital, anybody here work in a hospital? Well, if you work in a hospital, you know that we do care about quality, and we do care about safety, we do care about best practices, standard of care. But if you're an administrator, what do you mostly care about? Money. Money, which is not to say that they're bad people, some of them are, but it's to say that they have to keep hospitals alive, and so they care about money. So why is growth like this occurring? Somebody is recognizing that palliative care saves money. And we have data now from about 8 studies, including, I think, 3 randomized control trials now. The largest study that was done using propensity scoring to create a comparison group involved data from 8 hospitals that collected data from 2002 to 2004 that demonstrated that a palliative care consult in a hospital saved the hospital about $1,696 per admission if the patient was discharged alive, and a very high $4,900 if the patient died in the hospital. So these kind of data for administrators is compelling. We also have data from a recent RCT, which I think many people view as a seminal study. This was published by Janet Temmel and colleagues from Harvard in the New England Journal last year. And this was a study that looked at 151 patients with newly diagnosed metastatic lung cancer who were randomly assigned to either get usual anti-neoplastic care, or I should say oncologic care, not just chemotherapy, but either usual oncologic care plus a palliative care referral, no stipulation about what the referral does, just a referral, or usual oncologic care alone. They then followed the cohort for 12 weeks, and what was determined is that after the 12 weeks, those who had early palliative care referral had a better quality of life, less depressive symptoms, less aggressive treatment of life, at the end of life, and remarkably, a longer survival by 3 months. So these kind of data, this is the kind of study that raises more questions than it answers, but it suggests that this intervention called specialist-level palliative care has a relatively large effect size, and if you provide at least some of it in a hospital setting, you will end up with care that doesn't shorten life, which would be poor marketing, right? It's hard if Mass General said, we have this wonderful care for you, all you have to do is die earlier. That would be a hard sell in the Boston market. But here we have this care. It reduces illness burden, it reduces suffering, it's associated with higher satisfaction ratings, and by the way, it doesn't shorten life, and it allows you to have greater choice in terms of aggressive management at the end of life. pretty compelling. Do you know how many times how many times each patient or family met with the palliative care team in this study during the 12 weeks? The median number of visits, can you guess? 4. 4 visits was the median number of visits over 12 weeks. So someone has said to me, well, what can you do in 4 visits that would lead to results like this? And I think the only fair and scientific thing to say is that it's magic. We don't really know. But something happens when you provide specialist level palliative care. And it seems to have a big effect size. But we have challenges in palliative care. The workforce is limited in all disciplines. After this year, there will be no more ability to get board certified as a physician without a fellowship. That's going to markedly reduce the growth in the board certified cadre of palliative medicine specialists. We have a very limited number of advanced training programs for nurses and for social workers. Chaplains are just now beginning to have a certification, and so we have a big workforce problem. Right now, in fact, an article that was commissioned by the American Academy of Hospice and Palliative Medicine suggests that we have somewhere between, I think it was 8,000 and 16,000 physician gap to meet the current needs of the healthcare system. That's without further growth in palliative care. So we have a big workforce gap and a limited means to improve the number of specialists. Cost avoidance for hospitals is established now, right? That's why all these hospitals want to start palliative care programs. But the problem is that if you're a hospital administrator, cost avoidance looks good on your P&L and your balance sheet, but it doesn't give you capital for program development, right? If you avoid cost, the only way you get money to hire people is if you cut something else. So that's the problem. You know, it's a problem in terms of hospitals adequately resourcing palliative care because they save money, but they don't have more cash on hand. We don't have any evidence at all that community-based palliative care is economically viable, and there is large geographical variation in resources around the country. So now let's turn a little bit to what's been happening in the healthcare system, both federally and at a state level, that will influence and potentially support this movement that's been happening in the U.S. I've suggested to you that in the last 15 years there has really been a dramatic change in palliative care in the U.S. and also in the rest of the world, with now subspecialty status in all the core disciplines and acceptance of the model, a drive by hospitals to have the presence of this model, growth of hospice in throughout the country that's been absolutely stunning. So lots of work to improve specialist level care and also some focus on generalist level care. Things have been getting better, but there's obviously these challenges, as I mentioned before, and there's still inadequate support for a very large population of old people who are sick, or sick people, some of whom are old, and some of whom will die. And there's not adequate support yet. So the question is, what are we going to do as a set of governments in a complex healthcare system to support what this has been about? So the first thing you need to know about, in case you've been living under a rock for the last 2 years, is that we do have health reform in the United States. It's called the Patient Protection and Affordable Care Act, Public Law 111-148, which was signed into law on March 23rd, 2010, and has elements that will roll out over a period of years. This law is intended to cost about $1 trillion over 10 years. It's intended to expand coverage to about 32 million uninsured Americans. The increase in cost is set or believed to be offset by $438 billion in new revenues and $500 billion in spending reductions. And it is intended to actually reduce the federal deficit by about $28 billion over 10 years. Modest effect on the federal deficit, a big effect on health care access and cost. This is what the Affordable Care Act is meant to do. The Affordable Care Act includes a new insurance exchanges that are at a state level. You've heard some states are delaying that because they're hoping that the Supreme Court votes down the mandate for insurance. Some states are driving ahead with this. Lots of concern about what the exchanges will have as the minimum policy. A lot of variation from state to state. Welcome to America. It's the way we do things here. There will be insurance market reforms, which have already taken place. It seems from the polls that many people in the United States don't understand how much better it is today than it was 5 years ago, but hopefully there'll be more recognition of that. You can't be cut off from your insurance. You can't be denied insurance for a pre-existing condition. Those sorts of things have been improved. There's significant changes to Medicare coming. Incentives for primary care, including geriatrics, meaning, of course, incentives for preventative care. You don't see their palliative care. There's expansion of healthcare workforce programs. Now, no evidence yet that will include palliative care specialist training. Expansion of Medicaid. And there'll also be a focus on prevention and wellness, care coordination, comparative effectiveness, quality, health information technology, fraud and abuse, and elder justice initiatives. This is all in the law. And this is the law that is driving the development of the patient-centered medical home, the patient-centered health home, and accountable care organizations, ACOs. The Affordable Care Act also includes demonstrations and pilots to lay the groundwork for fundamental delivery and payment reforms through these sorts of initiatives. Probably the most important principle here is that the Accountable Care Act, the Affordable Care Act, is going to drive the healthcare system away from reimbursement for fee-for-service and toward shared risk. That's the fundamental principle. The fundamental principle and why this law is believed to have the potential to reduce healthcare costs is because when fee-for-service medicine becomes less prominent in the U.S., less will be done to patients. So now, shared risk can occur in a variety of ways. The simplest way probably are bundled payments for episodes of care. We've seen that in hospitals with DRGs. We've now seen that in the ambulatory settings with APGs. We've seen that in dialysis. So bundled payments are a key element of this. But in the larger scope of things, it's the medical homes, the health homes, the ACOs. This is what's going to happen. This is what's going to fundamentally change healthcare. Importantly, palliative care is not specifically included in any of these models, but it's well positioned to be an important factor. Why is it well positioned to be an important factor? Because it saves money. And that's why, for example, the Montefiore Hospital's CMO organization, the managed care organization owned by Montefiore Hospital, has been told that it is getting an ACO demonstration project, and they've immediately reached out to MJHS Hospice and Palliative Care and say, can you be part of the ACO initiative that we're going to have in some of our nursing homes? So hospice and palliative care in that ACO is going to be placed in the nursing home part of it, because access to hospice and palliative care nursing homes reduces hospitalization, reduces emergency department visits, and saves money. So this is how we have hope that palliative care is going to be a key player in this. What about in New York State? The federal law is coming, but New York State has jumped ahead in a variety of different ways. According to the Center to Advance Palliative Care's 2011 state ranking survey, this is the report card on hospital-based palliative care. You can see that if you look at the national data from all hospitals together, hospitals of 300 beds or more, 85% of them have palliative care programs. Hospitals of 50 beds or more have 63% of them have palliative care programs. If you look at New York State, 89% of the larger hospitals, 75% of the smaller hospitals have palliative care programs. So that's good. And New York State gets an overall ranking of B on a scale from A, B, C, D. And most states have actually improved between 2006 and 2011. There are a couple that are still remarkably terrible, though, like Mississippi. But New York is a B. So New York is making progress in providing access to specialist level palliative care, and more importantly, there have been 3 laws that have been created in New York State. These are all now laws. They've been passed and they've been implemented, and these laws can be expected to fundamentally change access to palliative care over the next 10 years. So you need to be aware that these laws exist. The first law is the Family Healthcare Decisions Act. That is the law that affects mostly hospitalized patients or patients in nursing homes. But it does apply to all hospice patients, even those in home care. It's been effective since June 1st, 2010, and this is the surrogacy law. You may have heard about this. This is the law that New York State passed in order to empower surrogate decision makers to make healthcare decisions for patients who lack capacity. We were 49th out of 50 states in having such a law, right? So 48 states had a law, and then we had one. And it took about 15, 17 years to get this law passed. But it's a very, very good law, in my opinion. It's very thoughtful, very clear about how to implement it in a way that provides an ethical foundation for surrogate decision making. So the bottom line is that this law empowers families and close friends to make treatment decisions for patients who do not have capacity. It doesn't apply to patients who have signed a healthcare proxy or patients with mental illness, mental retardation, or a developmental disability. It repeals the old DNR law. We no longer have a DNR law in the United States, in New York State. It establishes a surrogacy hierarchy so that if the patient doesn't have an agent, meaning to say there's no healthcare proxy, but the patient has others in his or her life, you can look at the others and identify a surrogate according to a hierarchy. It respects oral and written advance directives, meaning to say that an expressed wish, when you are a sentient adult, if you have a wish about the care you want to receive and you express it clearly through a living will or an oral advance directive, after you lose capacity, if the context is right, health professionals are required by law to do what you wanted. Expressed wishes trump everything else. That's now embodied in the law. And it also establishes procedures for surrogates to consent to treatment or to consent to withhold or withdraw treatment, including doing a DNR law. And it establishes procedures for physicians to do this if there are no surrogates. So this is very profound stuff. And the good news is that after a full year, Beth Israel Medical Center now has completed the forms that will allow us to implement the Family Healthcare Decisions Act on the units. And those forms, according to the little bird that informs us about this, have now been completed at the printer, and they're on their way here. So sometime in the next month, and may I be struck by lightning if I'm lying to you, these forms will be on the floor. The old DNR forms that relate to a law that hasn't existed since 2010 will be off the floor. And you will be able to help families make decisions for people who lack capacity by going to the form and following very clear instructions that will force you, in essence, to comply with the law and also provide an ethical foundation for decision making. It's a really good thing. Now, what about the Palliative Care Information Act? This is unique in New York. There's no other state in the country that has something like this. California has something that they want to take credit for as being something like this, but it really isn't something like this. This is much better than that. So this law went into effect February 2009, and it applies to every attending physician and nurse practitioner with primary responsibility for a terminally ill patient. If multiple providers have responsibility, it applies to every single one unless they agree as a group that one will take responsibility. And what does it do? The law requires a physician or an NP with responsibility for the patient to make an offer to that patient to have a discussion that will involve information and counseling concerning palliative care and end-of-life options. The law says that if you are a doctor or you are a nurse practitioner and you have primary responsibility for a patient who is terminally ill, meaning to say 6 months or less as you would apply hospice, if that exists, you are required by law to offer a conversation to the patient or to the patient's authorized representative if the patient lacks capacity. If you don't offer a conversation, you're in breach of the law and you will have to go to prison. If you offer a conversation, you have to offer a conversation about palliative care and end-of-life options, and it often includes the range of options appropriate to the patient's prognosis and the risks and benefits of various treatments and the patient's legal rights. And if you don't want to offer a conversation, that's okay, but then you're obligated to refer the patient to a qualified professional who can offer the patient a conversation. If you don't want to offer a conversation and you don't want to refer the patient, then you have to get rid of the patient. You have to refer the patient to another professional. That's what the law says. So we know that very few professionals in New York State are following the law now. My preference would be to put everybody not following the law in prison, but that might make access to health care a little challenging in the state. So we're not going to do that yet, but the Department of Health will begin. It has initiated education, which is good, and it will begin ultimately enforcing the law, probably through institutions. So, for example, when the DOH gets a complaint and comes to Beth Israel Medical Center to investigate the chart of a patient who has a complaint against the hospital, they'll look in the chart to see whether or not the physicians involved in the care of the patient complied with the Palliative Care Information Act. And if they haven't complied with the Palliative Care Information Act, they can fine the physician $2,000, and they can fine the hospital. Hasn't happened yet. There are no definite plans to have that happen. The investigators haven't been trained, but the DOH lawyers who are responsible for this make it clear that there are mechanisms for enforcement if education doesn't work. They're not viewing this as a law intended to educate. They think about this as a law intended to be complied with. So whenever you see a patient who has an advanced illness, you need to write down, I have offered the patient a conversation about palliative and end-of-life options, but she refused. Or I offered a patient a conversation, and after that offer, we discussed the following. Or I have referred the patient to the palliative care consult team in order to offer a conversation. So this has to be evolved. Finally, in New York State, just very recently, a new law went into effect called the Palliative Care Access Act. This law doesn't apply to providers, but rather it applies to hospitals, nursing homes, home health care agencies, and enhanced assisted living residences. And what this law says is that the facility has to have policies and procedures that provide access to information and counseling about palliative care, and it has to facilitate access to appropriate palliative care consultation and services. So no institutions in New York State are yet dealing with this. I myself have drafted a policy for Beth Israel and maybe SLR, which is now in discussion about how we're going to do this, but this is another law. So what I've tried to convey to you is that palliative care is now an established model of care in the United States and in many other countries around the world. It's rapidly grown as a model of care and is evolving in the healthcare system at both the generalist level in terms of best practices and, more importantly for us, a specialist care largely provided in hospice agencies and consultation teams in hospitals and nursing homes. It offers improved quality of care for the chronically ill and those with advanced illness. It reduces costs and therefore can be part of the solution to healthcare cost crisis, which is why I'm very optimistic that my chosen subspecialty will survive in the next 10 years. For those of you who are doing hip replacements, don't be so sure. Or epidural injections, I'm sorry. And in New York State, specialist level palliative care can assist in complying with our laws, Palliative Care Information Act and Palliative Care Access Act. So having specialist level palliative care in this institution is a big plus if you're a provider and you access us through the consult team, or if you're an institution and you access and you're able to say to the state, we are complying with the Palliative Care Access Act in part by having a specialist level palliative care program and a hospice program on site. In the United States, in the next 10 years, I think you're going to see more access to hospice with more focus on hospice quality There'll be one-year eligibility in managed care, supported hospice programs, and possibly Medicaid. The state has already passed a law which would allow for a one-year eligibility for some programs. Medicare is unlikely to do that, but Medicaid might. There'll be concurrent care pilot under Medicare coming up probably after the next election. We're going to continue to grow institution palliative care programs using cost avoidance models and possibly expanding into specific sites like ICUs and emergency care. And this is probably the most important thing, in my view, which is the development of community-based palliative care programs that will be based on shared risk cost avoidance models, meaning to say that we'll be part of ACOs or part of managed care companies that will pay for palliative care in the community and thereby provide reduced cost to the overarching model by reducing hospitalizations. And I'm going to stop there.